be within, thank you, John, within the next minute or so. So as soon as we have a few more folks in the waiting room, as soon as everybody's starting to be admitted, we will go ahead and get kicked off, because once again, we're really thrilled to have our colleagues from Quantified Ventures here. I'm excited to hear their knowledge specifically around the topic of managed care organizations. I think this is something a lot of folks are really eager to learn about. So we'll just give it one more minute as there are still some folks coming in, and then we'll get started. All right, so to make sure that we have enough time, we had a really great discussion last week as well for those of us who joined us. So want to make sure we have time for that today. So we're going to go ahead and kick things off this afternoon. So welcome to our webinar today on medical respite programs in managed care organizations, recommendations around sustainability. And we are thrilled again to have our colleagues Susan Donovan and Chester Cruz from Quantified Ventures here to share in this conversation today. Before we get started, I would like to do our labor and land acknowledgement. Since myself and Susan and Chester are all in different locations, this labor and land acknowledgement, similar to last week, is focused on our organization's headquarters, which are in Nashville, Tennessee and Washington, D.C., which is not where any of us are, but it is the center of our organization. And we're really trying to integrate these land and labor acknowledgements in our work with the council. So I honor and acknowledge the original stewards of this occupied land who stand on the unceded ancestral lands of the Cherokee, who currently and historically reside in Tennessee, and the Yuchi and Ashawnadasi-Tula people, past and present, and honor the gratitude the land itself and the Cherokee, Yuchi, and Ashawnadasi-Tula. We also honor and acknowledge the original stewards of the occupied land of Washington, D.C., and there they stand on the unceded ancestral lands of the Nacotchtank and Piscataway people, past and present, and honor with gratitude the land itself and the people. And we acknowledge the labor of Black and African American people, ancestors and descendants, and recognize the United States and global economies historically and currently reside on the ingenuity, cultural treasures, and soul and labor of African Americans and Black people throughout the diaspora. We honor the brilliance and humanity of all immigrant labor, including voluntary, involuntary, trafficked, forced, and undocumented peoples who contributed to the building of the country and continue to serve within our labor force. We express our heartfelt gratitude for their infinite contributions, and by recognizing the land that was taken from first Americans and the forced labor that was provided by enslaved Africans and Black and brown people, we strive to take steps towards creating a more equitable and just world for all of us. So thank you for that moment of reflection with me today. And I'm going to go ahead and turn it over to Susan and Chester. Thanks so much, everybody.
Awesome. And I think Chester's going to pull up the slides here, and I will kick us off. So as Caitlin said, my name's Susan Donovan. I'm a director on the Health and Human Services team at Quantified Ventures. I'm here today with my colleague Chester. And this is part 2 of a 2-part series. If you missed part 1, don't worry. We have designed these to be both reinforcing, but also self-contained. So that means if you did join us last week, there's some slides in here and there's some content that will be a bit of a refresher. But also if you didn't, then you should still get something out of this as well. So what we did talk about last week, and for those who did not have a chance to join, we talked more broadly about the benefits of pursuing an earned revenue model for programs like medical respite, and then talked generally through the steps and processes that we use at Quantified Ventures and that we have seen other providers use to pursue value-based contracting arrangements that work towards those earned revenue models. Those materials, my understanding, have not yet been posted, but are in the process of being posted on the NIMARC website. And Caitlin has graciously agreed to share with this group as well once those are all available. So if you've not looked at that, we really encourage going back and reviewing that as well, and getting a sense of kind of the broader dynamics around earned revenue approach. So jumping into our goal for today, really what we want to do is double click on the dynamics behind engagement with managed care organizations, and specifically Medicaid. A lot of what we've got today is around Medicaid and focused on the dynamics in that managed care setting. I will say, and happy to talk offline, there are the principles and the approach here in particular is more broadly applicable, and has some overlap with Medicare Advantage managed care as well, although that's not the focus of what we're going to dive into today. So what we're going to do generally is we're going to talk through some like high level background. It's going to feel a little bit like back to school for a second here. And we're going to do that not so that you like memorize all of this. There will be no quiz at the end, but really we want to try to ground the group in the different underlying dynamics within Medicaid that have meaningful influence on things that you are going to see on the ground, you are going to hear from prospective partners that are not always obvious where those things are coming from, but hopefully help pull back the layers of the onion to understand those dynamics a little bit better so that you can be informed and knowledgeable as you're engaging in these conversations. After we do that, I'm going to hand it off to Chester, and he's going to talk through more of the process and how we've seen that manifest specifically within engagement with Medicaid managed care. So that's our overall flyby. But before we jump into that, just a couple of words here on who we are in Quantified Ventures. So QV is and I will use QV as shorthand for Quantified Ventures frequently in the conversation. We are a consulting firm based in Washington, D.C. We are a B Corp, so we are both rooted to our mission orientation as well as generating return. And we work across health and human services and environments, working to develop investable solutions that improve the health of people and planet. And really in the healthcare practice where Chester and I work, we live in the space between Medicaid managed care and community organizations that are addressing health-related social needs, and really trying to come at it from a very quantitative, logical framework of mutual business interest, but also the really nitty-gritty of partnership development and how do we figure out how to bring these two worlds and work together. And so you'll kind of see that dynamic come across in the conversation today. And did want to also just kind of share on the next slide, we've work very frequently in this housing space, frequently with medical respite, and have worked to kind of across the country in various ways on medical respite and housing and the intersection with Medicaid managed care. And so we've seen this manifest and these dynamics play out in real life in a lot of different settings. And so part of our goal today is to kind of help distill that and share back with you all what we're learning from those processes. So with that, this is the back to school portion of the agenda. So starting at kind of at the basic levels here, Medicaid, the largest insurance provider for low-income individuals in the country. It is a partnership between the federal government and states to organize and deploy. States have significant flexibility in how Medicaid programs are structured. So, right, like unlike Medicare, which if you have Medicare fee for service, it kind of looks the same no matter where you are in the country, Medicaid varies very significantly. There are some flexibilities that we want to highlight here because they have downstream effects, but we want to root ourselves first in what those state Medicaid flexibilities are before we kind of think about their impact. So the first is just the concept of managed care, right? So managed care, essentially when states contract with private companies to manage their Medicaid benefits for Medicaid enrollees. This is not a thing that happens in all states, right? So like most states have some form of managed care, 41 at the last kind of best counting we can find. The contracts typically last 3 to 5 years, with the MCOs bearing kind of financial risk of managing the Medicaid enrollees' cost of care. That is, again, something that is pretty ubiquitous at this point in terms of what you see across states, but there are states still out there where there is not a footprint of managed care. All right, next one. The population and service carve-outs, a piece we want to highlight. So within managed care, there are carve-outs, and you may have kind of heard this terminology being thrown around, right? So these are either populations or services that are carved out of those Medicaid managed care contracts. Those are either managed through a separate managed care that's just for that carve out, or can be kind of retained as fee for service direct to the state in an arrangement. Things that are frequently carved out in services, long-term care, pharmacy, behavioral health, populations that tend to be carved out, frail elderly, foster youth, individuals with SMI. Again, we'll talk about the implications of all of this on the next slide. Next thing, eligibility and expansion. As most folks likely know, unless they've been living under a rock for the past 10 years, the Affordable Care Act allowed states the option to expand who is eligible for Medicaid. And so 38 states as of this point have expanded access to adults through the Affordable Care Act that have higher income thresholds, much less stringent criteria for adults accessing Medicaid. That's a big point of flexibility and difference that exists. And then the last is kind of benefit design and structure, both at a kind of basic healthcare services level. States are required to cover a minimum set of services required by federal law, but all states in some way cover services that are not mandatory, but for which the federal government provides them matching dollars. And that's important for the state, right? Like they significantly prefer to be covering services for which they are getting a federal match. And so that plays into the dynamics of many of them, as they are pursuing tests of new approaches or different models, will go to the federal government and receive different waivers. 1115 is the one that's kind of most frequently used in this space to be able to receive federal matching dollars and update their Medicaid programs to cover expanded services. So synopsis here, there's a minimum standard for the federal government sets. States have a lot of flexibility. And really how this manifests, right, is on the ground, Medicaid looks very different in every state. The dynamics and the nuance are different in every state. And so there is, what you will see today will be reflective of a suggested process that is going to take into account these things, but that, there is not a clear, this is the path forward, given that difference on the ground in every environment. So let's move now so these are now these same flexibilities that we just talked about, but as I noted, they have pretty significant impact on the potential for contracting related to health-related social needs, of which we kind of put medical respite into that bucket, right? So on the managed care side, kind of fairly straightforwardly, right? Like if there is no managed care in a state, there is pretty limited opportunity to engage with a managed care plan, obviously. And there's not really then a business, privately held business that has an interest in bearing financial risk for this population. And so obviously a lot of limitations there around contracting. The population and service carve-outs will impact which outcomes MCOs, Medicaid managed care organizations, will have a business interest in improving, right? So like an easy example here is if long-term services and supports are carved out, MCOs aren't going to be financially incentivized to reduce long-term nursing home stays compared to a state like California, where long-term services and supports are in contracts. That becomes a significant financial incentive for Medicaid. So that's a key thing to be kind of considering, and affects the dynamics. And then the population carve out similarly can have an effect on which potential individuals in your target service population will be included in a contract with a specific MCO. So the medical respite example here is in states like Florida, where SMI, individuals with SMI are carved out, that can have an impact for medical respite contracting, given, depending on your model, given how much you would expect those that you are in your facilities to have SMI and likely then be covered by that carved out plan and not by kind of the typical more standard Medicaid plan. Eligibility and expansion, essentially what this looks like is, in states that have not expanded Medicaid under the Affordable Care Act, there are significantly smaller portion of the kind of low income adult population that's covered through Medicaid. Kind of the way that this manifests related to medical respite is, we see in expansion states, there's some great data that 65% of individuals that are served by healthcare for the homeless providers are covered through Medicaid in expansion states. That's compared to just 20% in non-expansion states. So that has a pretty significant impact on kind of potential for contracting with Medicaid for the homeless population. And then finally, on the benefits side, we see states like California and North Carolina that have begun testing reimbursement specifically designed to pay for health-related social needs. We're also seeing a movement towards more states exploring medical respite service reimbursement specifically, but that's going to be a kind of a key difference that impacts approach of obviously whether a state has dedicated medical respite funding versus not. All right, that was the most caloric of the slides I've got. So we'll continue to kind of contextualize that now that we've got that baseline here, and thinking about what the opportunity is to work with Medicaid managed care. So the good news, right? Healthcare and Medicaid specifically are deepening their commitments to health-related social needs and social determinants of health. There's a big push from the state level that more and more Medicaid contracts that are being renewed in that kind of, as we said, 3 to 5 year period, the states are incorporating more and more SDOH, health-related social need components in what they're doing. There has been an uptick in 1115 waivers for social determinant of health provisions. And the CMS has recently provided some guidance that is encouraging adoption of states to pay for things that address social drivers of health, and giving them flexibility to do that without having to necessarily get sign off from the federal government. There's a couple of other things here that are going on in the hospital space and in the physician space as well that are all really supporting movement towards screening and referring related to social determinants of health. But on the next slide, one of the things that we're observing is as reform is kind of pushing on this screening and referring for health-related social needs and social determinants of health, we see this in 25 states have added to this to their Medicaid requirements. This is stuff that people are more familiar with. It's more similar to kind of the screen and refer approach that's used in clinical care. There's a lot of really great work that's happening there. What we're observing and what we're hearing from a lot of community-based providers is that's creating this pressure on the organizations that have to address those health-related social needs. And there is not necessarily the kind of matching investment to address, right? So address health-related social needs. So that is actually using Medicaid to pay for those things is much more kind of leading edge, used in fewer than 5 states. And it's also just like harder work. It requires more robust partnership. So it takes more time, quite frankly, than some of the other pieces. But I think the good news is that because of this dynamic, right? Like we presented this slide at like the biggest Medicaid conference last week, and we got like a bunch of people nodding their heads, right? Like Medicaid understands that this concept is happening, and is trying to figure out where they fit into it. And so that allows, kind of creates a moment where there is an opportunity to start engaging in these conversations. Medicaid managed care plans have several mechanisms available to pay for services that address health-related social needs. We will be honest, right? Traditionally, these are organizations that are really looking to contract and pay for services that are aligned directly with the state coverage requirement. So like the state says I have to pay for it and contract for it, and I will. And if they don't, I won't. And so related to health-related social needs, MCOs are obviously much more than familiar with paying for health-related social needs that are part of these explicit waivers that the state has gotten federal sign-off to pay for. That said, there are other ways that Medicaid managed care plans can contract to pay for these types of services outside of state level action and things that are within their control to do. They may or may not, depending on which plan you're talking to and who you're talking to, be familiar with the fact that these mechanisms exist. I cannot count the number of times I've been on calls with managed care plan representatives that have said, I cannot pay for things that are not covered benefits. And what I want to say in that moment is, you will not pay, you won't pay, but it's not that you can't, right? And so there are different kind of fairly complex mechanisms that are available to them. We have highlighted the 3 here that are most relevant. There's a whole host of like resources and information and nuance about all of this. The sources that we've cited kind of in other slides here are really like a wealth of information. And so if this is something where you're like, I need the detail, encourage you to go and look through some of those resources that we have linked that have a lot more detail. But the goal here is to kind of help give you a flavor. So let's talk through those mechanisms quickly here. The first is value-added services. So these are additional services that are outside of covered benefits that improve quality and health outcomes. So things like home modifications, nutrition classes, those are considered value-added services. There's also community care coordination services. This is an obligation that MCOs have across, and this is one of the things that is consistent in all states, is that MCOs have a contractual responsibility to coordinate health and social care for the individuals that are their members. And so any components of that coordination that's part of medical respite or addressing health-related social needs can potentially fit under that mechanism. And then the last here is what's called in lieu of services. These are services that are substitutes for services that are covered under the state Medicaid plan. So, and this is the approach that actually in California, they call it community supports in California, but this is the mechanism that California is using for medical respite, with the kind of logic that it is an alternative to hospitalization, to other settings of care. And again, that is something that that is available to both states to do without federal approval, and MCOs to do without state approval. Although, for reasons we'll talk about on the next slide, the MCOs may be often look towards the state for guidance around those in lieu of services, or also called ILOS. All right, so depending on, we talk about those mechanisms because depending on what mechanisms and MCOs believe they can use to pay for services that address health-related social needs, that has downstream financial impact for them as MCOs. So the two big ones are what we've highlighted here. So the first is, how does it affect my medical loss ratio, also known as the MLR? So quick and dirty primer on MLR. MCOs have to maintain a minimum threshold percentage of their expenditures that are related to quality service, quality improvement in clinical services. That essentially means that MCOs are disincentivized to invest in anything that they can't count in those clinical services or quality improvement. The good news is that there's been a lot of federal guidance and support for the idea that value-added services, community care coordination services, in lieu of services, all of those things count as clinical services. So regardless of where an MCO ends up kind of rationalizing and putting a program like medical respite, it really is almost certainly going to end up on that numerator side of the MLR, as we call it. The second is the impact on future capitation rates. So as we talked about before, MCOs are paid by the state through regular capitation payments. Those payments are adjusted on a regular basis to account for cost increases based on historical spending. And so for MCOs, they are incentivized to invest in services that they can include in those capitation calculations. Those calculations look very different for all states. There's not a lot of transparency about that, but that is a question that will be on their minds: is, can I count this in my capitation calculation with the state? For this one, the community care coordination services and in lieu of services, if getting kind of bucketed in those categories, are things that there's been federal guidance can be included in capitation calculations and should be included in capitation calculations. Value-added services explicitly are not included in those capitation calculations. And so that is a dynamic to be aware of if that sounds like where things are going with medical respite, of having it be a value-added service instead of one of these other tools, is that there's that downstream capitation impact. I'm going to pause before I hand it off to Chester and just say, we shared all of that, as I mentioned at the top, because we want to try to help give you all the information to know what potential MCO partners are going to be thinking about. You know, these are terms you may hear them raise in conversation, and we want you to be educated and aware of the dynamics and the things that they are thinking about through this process. You may never actually know where they decide to categorize a medical respite contract. It is fully up to them at the end of the day where they're comfortable categorizing any kind of contract with a medical respite provider or any health-related social needs provider. It will almost certainly not be transparent to you what the final kind of call is there, and that's okay. But we still find it very important to be kind of well-versed in those concepts as we're engaging in conversations. So I will leave it there. And now I'm going to pass it off to Chester, who is going to talk through the strategies and tactics that we use related to medical respite contracting with managed care specifically.
Cool, thanks. Yeah, so we're going to go into a little bit more on the next few slides on the overall process that your organization could follow to try to contract with an MCO. So I'll start with, my screen allows me to go to the next slide. The slide that for those of you that joined our last webinar may have seen a slide similar to this. And what we wanted to highlight here was there's a lot of services that your medical respite program may be providing, some that you may not be, that are on this list. And the point here is that a lot are reimbursable services, and we also acknowledge and know that a lot are also non-reimbursable. When you start to think about going to a possible MCO payer, one of the first things you want to start to do is indexing what are the reimbursable services that are available to you and your organization, and are you actually billing for those services? So trying to get that entire model down as to how much money you could possibly bill for the particular services that you're providing, recognizing wholeheartedly here that even that amount of money or the services that you're billing are probably not paying for the entire cost of what that actual service is to be there. But it's important that we start from at least a initial jumping off point to understand what are the services that you have the ability to bill, and that you are actually billing, and what are the ones that are non-reimbursable services that you're providing. And that leads us into developing value-based contracting via the viable earned revenue models. So if you joined us last week, and we put this blurb down here at the bottom, we talked a lot about what even is an earned revenue model, and discussed different options around how you get to an earned revenue model. We then dove a little bit deeper on value-based contracting as a whole. And so what I'm going to do today is take that exactly kind of right where we left off last week, where we said, here's what value-based contracting is as it relates to earned revenue. And now take that a step further and say, here's the way that this could be done within a managed care organization. And so in the next few slides, we're going to go through each one of these buckets that we view as part of a financing arrangement for value-based contracting. At a high level, I'm going to quickly hit on these. The payments are associated with the outcomes that they provide. And so this is where we really start to think about what are the actual outcomes that your program is able to achieve. And then how do we understand what the quality value of that particular program is. Second bucket is payments are fully or partially conditional upon those pre-targeted outcomes. So this is where we'll talk a little bit deeper in a few slides here around what is the level of risk that your organization wants to take on. In other words, do you want to be just getting paid based on doing certain activities that you normally would do, or are you willing to be a little bit more riskier with whatever your outcome is that you're trying to achieve, but also understand that there's a higher payment involved there? And we'll touch on that in a few slides. And the last is the outcomes-based financing. So this is the entire structure that then is able to be implemented with that possible MCO, may involve some external capital to finance upfront costs, but pays your service organization based on the outcomes that they're able to achieve. So I'm going to start with this next couple of slides here with an example, because I think what we'll do is we'll reference back to this example in the next few slides. So Quantified Ventures started working with NSO to develop a medical respite program in Detroit. And so when NSO came with QV, they knew they wanted to develop a medical respite program. They had to get a facility. They had to create a program, and then they had to also find a way to financially sustain that for the long term. And that's where we jumped in and started to work with them. And so the model that's being shown right now is what we ended up developing with them, this outcomes-based model. So there's a couple different components going on the screen. So the first being NSO had to figure out a way to at least just fund their initial operations that they need to get up and running. And through that, we did a mix of grant and debt funding through two philanthropic organizations that you see on the left-hand side there. Next, we wanted to set up what are the outcomes that this organization is going to achieve, and how do we find a payer that would be willing to pay for those outcomes. So we started identifying possible outcomes such as housing placement, and wanted to then find a payer that made the most sense that would be able to partner with them. And we could dive deeper into how to even find a payer, but I'll be honest, just to start, a lot of it is pure networking and going through your network to say who exists that could possibly be a payer, bring them into a conversation and say, here's the model we're thinking, and bring them along as that thought partner as you start to develop what that outcomes-based model looks like. And so in the case of NSO in Detroit here, we identified Molina as that possible payer here. And I'll note the slide you're seeing here is what we've implemented and is going on today. We also are still working on bringing in additional payers to also be part of that outcomes-based financing arrangement. It's certainly not a one-payer system in Detroit, and Molina is not the only one that has skin in the game there. So in the next few slides, I'm going to reference back to this example and provide additional context as well, which is why I'm not going to keep going here. So when you're going to target payers, this screen or model that we're showing here is exactly what we worked with when we went to develop this model with NSO. And so the first bucket here is the be curious, understanding what the goals and strategic priorities are. This includes not only the potential payer, and so in the case of NSO, the Molinas, but it also includes what are the goals and strategic priorities that Kresge and Rocket Fund were also looking for as well, as they were going to be those initial funders to help set up the program. What are the factors that drive the overall financial performance? And this is where we get into some of the initial cost modeling that you would need to have set up in place so that you're ready to approach these potential payers for the conversations. Own the math is taking ownership of your financial projections. And I'll drill deeper on the next slide here on the way that we think about this. But this is where your program starts to develop into what are the actual total costs that I'm putting into my program? What are those services that I am getting reimbursed for at this point? What are the services that I'm not? And where's the overall funding gap? And how can I stand behind it when I'm going and talking to a potential payer? And the third is the be flexible. And so this is just understanding what your non-negotiables are. We have a couple of examples specifically in the NSO of understanding there's non-negotiables. And defining your overall payment and outcome model that you're looking for. So in the case of NSO, I think we'll just reference directly back to that. We started with this. If you look at this table at the bottom, very, very similar table that we went to Molina with initially within the NSO project. And so this was looking at a lot of national averages to determine what were the cost savings per medical respite admission. And what we're able to do is, as I mentioned earlier, bring that payer along as that thought partner here and say, here's what we found based on all of our literature review and the research that we were able to do. Is this validating with what you're seeing and what your data is able to provide? We'll look at your data with you and figure out how close this matches it so that we can figure out if what we're even proposing here makes sense for your organization. In the case of Molina, I think this was as close to spot on as you can get. It was just like barely off the national averages here, which really accelerated that conversation and made it easier for us. But it's important at this stage and for your first step to know what those outcomes and the value projections are that you're looking for, and bring your estimates and be able to stand behind what your estimates are as you go into those initial conversations with your potential payer. This next step is thinking about risk. And so I mentioned kind of the be flexible, and I think that goes hand in hand with risk tolerance in some ways. And so there's two different types of risks to consider when going through value-based contracting with a MCO, upside and downside risk. So upside basically means that you're going to get your base payment regardless of the outcomes, and you're able to just basically get this additional outcome payment as a bonus. So you're only going up or only getting more. Your downside risk means that the base payments are not covering what you your full cost to operate as is right now. In some ways, I'd argue that you're always, as a medical respite program, always in this downside risk bucket, and that's the whole point of what we're trying to achieve here, is how do we get out of that. Within those different two categories of risk, we separated this into subcategories as well as the total payment that you're looking for from your outcomes, and then the outcomes of the direct value that it's actually providing to the MCO. And so these are not like perfect cut in stone or lines here around low, medium, or more risk. They're just examples as to how you could start thinking about on this continuum of risk here. Specifically in the NSO example, they were willing to go as much, not as much, but a significant amount of risk on the outcome piece, because they felt pretty strong on what the outcomes are that they would be able to deliver. So their daily rate was somewhere around like a 60 to 70%. And the rest of the program was funded by the outcomes that they were able to deliver. And that was a choice that they made when they sought their payers and those initial contracting conversations with Molina. We've worked with other organizations in the past that are as far to the left on this continuum as you can get. They want to get as much of that covered as they possibly can, with the intent that as they advance their program with that particular payer, they can start taking on more and more risk. And so the way Susan and I have talked about this before is this glide path idea of we start out being very low risk and moving into this higher risk, but also higher reward that comes with it as we get more reps and advance our program. And then last is thinking about the flexibility when you're going into these initial conversations with MCOs. Understanding what your ability to be flexible and what your non-negotiables are is super important for these conversations. So in NSO, just for example here, there were 3 really big non-negotiables that they had. Everything else was on the table. And so those 3 non-negotiables were they wanted a specific pre-authorization process that was going to be put in place so that they weren't worried about whether or not the member would be authorized. They didn't want to deal with any market rate debt, and they were not going to go any more. They felt that they were already at the highest risk they could go with those outcomes. They didn't want to go any higher on those outcome payments. And so what's really nice walking to the table there is those are our non-negotiables. Everything else we will do whatever that MCO really wants to think creatively about and ways that they may want to change that process. I realize that we're coming close to some time here and getting into Q&A. So I'm not going to read the rest of this, the great Mike Tyson quote, but just basically be flexible as you go through this entire process with your MCO, but also know what your non-negotiables are. So in summary, this is I call this like this 4-step process, but also none of this is ever in order. So, we start with quantifying the value, understanding what your entire outcome model could look like, what are your service model, and what are the MCOs that you'd be able to go to. Develop that cost benefit financial model, own the math as you're doing it, and then be able to establish those contracts and be flexible throughout the entire contracting piece there, but also know what your non-negotiables are with that payer. And the last one here, while I again label it as 4, it's definitely non-sequential. It's more throughout the entire process, document. And I think going back to, and my last piece on this NSO, yes, we're up and running with Molina, but we're also looking at other payers as well. And so having that document already in place puts us 45 steps ahead of any other piece of process that we'd have to go with there. So I will conclude there. We're happy to share more details and resources. Feel free to reach out to us. I think Caitlin will send out the PowerPoint and the webinar, but also our email addresses are there, so feel free to email us as well. And then we'll open up for Q&A.
Great, thank you both so much. We have some really great questions in the chat, so I'm gonna start at the top and we'll see what we get through here. And I just want to note that Susan did answer Blake's question in the chat, so we won't bring that one to discussion, but really helpful to know. So I'm going to bring up Molly's question. If a local medical respite provider wants to break into local, regional, or statewide conversations about advocating for respite service reimbursement, where does a local respite provider start? Any suggestions?
Yeah, so I would say two things, because I think that question is asking about like advocating for that state level payments, and that is certainly important and a big piece of helping move towards sustainability for these things. So I will answer that question, and then I will, I think, answer a slightly different question that may be in there as well, which is, how would they start to kind of advocate for this approach with Medicaid plans that actually does not require that state level action? So I think on the first side, right, it is trying to engage, like, as Chester said, with the network that you have, who knows who, how do you have these conversations with whoever will listen to you? The case that you need to then make, and like when you are at those tables, actually like is different math for a state, right? So like what we talked about today, and this approach is really designed to be meaningful to a managed care plan. That's actually like the calculation and the mental math and the considerations are very different for a state audience than they are for a managed care audience. And so I just wanted to make sure that that distinction doesn't get lost. But in terms of like trying to engage, if you're a local provider trying to engage with MCOs, again, like tapping your own network. The other thing, basically all states have some kind, with managed care, have some kind of managed care like society or organization. Almost all of those have some kind of annual meeting that is open to other organizations. And so just showing up in those spaces that they are going to be in, and both from a way to like understand the pressures they're under, what priorities they have, but also to start having conversations and trying to meet folks in that sphere is where I would recommend starting if you're not able to kind of tap existing relationships.
Great, thank you. Another question from Beth is that since these models involve more risk, where should an organization be in terms of their balance sheet? Any financial indicators or metrics that an organization should meet before they consider moving into a value-based approach?
Yeah, I will say some of that is a little bit of what we talked about on the last meeting. So there's some content there. You know, I think that is a very personal decision for provider organizations. And, you know, I don't know that anyone can make that call for you, other than to say, you know, you should have a solid grounding in your, you know, financial management, and be kind of confident and not, you know, if you are struggling to break even on a regular basis, you know, that is probably the first order of business before this type of an approach. But, you know, how much cushion is necessary and how that translates into how much risk you are going to take on as an organization, that's kind of a deeply organization specific decision that, that's going to have to come down to you, your organization, and your leadership.
Next question here is, have you seen health systems with population health contracts incorporating medical respite care into their contracts?
So I want to answer what I think that question is, but I'm not sure that I'm going to get it right. And Chester, feel free if you have a different interpretation. I think what that's asking about is like hospital health systems that are parts of like ACOs or clinically integrated networks, et cetera, moving into payment for medical respite. One of the things I will say as a broad statement for that in this space of kind of health related social needs investment is that the incentives and the kind of financial math for like an ACO is a lot harder than the math for an MCO. The MCO like gets all of the money up front, like they're holding the bag, and anything they can do to save is much more directly like just still in their pocket, versus an ACO or other kind of clinically in a network like shared savings type of approach that they don't have, right? Like they have very little to no upfront, and it's all on the back end in the rears and mixed up with a bunch of other stuff, right? So for that reason, broadly, we have had less, we've seen less opportunity to engage in like hospital-based population health in that way. The one massive caveat I will say for medical respite specifically is this dynamic. And again, it's very complicated. There could be a whole separate thing on that, and it probably have the same conclusion that it's different in every state. But, for medical respite, and you all are, I'm sure, familiar with this dynamic on the hospital side, is that, those extra days that an individual is staying in a hospital are likely to be, hospitals are likely to be getting little to no compensation for that. And, for people who are uninsured, getting very little compensation in general for those folks. And so, we see a greater opportunity for making the financial case and using this approach from that angle than from kind of the pop health ACO angle with hospitals and health systems. And, those are conversations we're having in Detroit, having in other places. We have to varying success, candidly, right? I think everyone knows that I think the state of hospitals post-COVID, and it's just really challenging for them at the moment, and has been tough to engage, if we're being frank.
Thanks. And I think I'll do Tyler's question here as our last question, so we're coming close on time. And I'm also going to launch our poll in that time while you're answering the question, Susan, for our attendees. But Tyler's asking, his local area has about 10 MCOs, which makes this process very daunting. Are there other strategies for localities like this, like talking directly with the state Medicaid, or just bite the bullet, pick someone to have a relationship and start somewhere?
Yeah, I like, it's kind of for me like a throw spaghetti against the wall and see what sticks type of thing, right? It's just like, yes, and like, if you've got a contact at the state level at HHS or at the state Medicaid agency, like working it through that and getting people around a shared table. If there's somewhere they're all meeting already, like trying to get in there, absolutely. May or may not be successful. And so then it's just like beating down doors and trying to work into the right people. A strategy I would suggest that we certainly used in Detroit is, being very aware of what those organizations' market share is. And, when you look at that, as we did in Detroit, we kind of looked at it and we said, okay, we've got similarly, I think it was like 7 to 10 plans in Wayne County. But if I get to these three, I can get to 50% of market share for Medicaid, right? And so you kind of know who to really push on and keep engaged versus those where you might say, hey, I'm going to deprioritize if this organization is not showing the most engagement in this conversation. So that's my recommendation, but it is a very complicated complicating factor when there are that number of plans in a place. But there's also like I will also say, again, we've seen this in Detroit and we see it other places. If you start with one, then there's like this FOMO thing that kicks in, right? Of like, oh, well, they're doing it. So once you get down the line and you like have your eyes on like, I think this is going to be the person that's going to like sign first, getting really in with them and then using that to assign contract with that organization to leverage with other organizations is another helpful strategy. Oh, Caitlin, you're muted.
I see that now. Thank you. Thank you so much, Chester and Susan, for your knowledge. I think this holds promise for additional conversations. These questions in the chat were really great, and there's definitely a lot of movement and action. To speak to Charles, your question around statewide consortia, there's some movement happening in there, so we can definitely connect around that as well. So I just wanted to plug a quick reminder for folks. We do have some resources related to this on our website, including our online course that talks about partnering with managed care organizations, which was written in partnership with Quantified Ventures. So a lot of really opportunity there to work deeply through some of these concepts. And then my last reminder for all of you is that we do have an all-member meeting coming up in November that you can register for now. We'll be doing some updates on NIMARC, but we'll also be doing a discussion on listening session on hospital discharge practices, which I think will be another really great and juicy conversation. So with that, we are at our time. Thank you again to Quantified Ventures for this great webinar series. We'll be sending out the webinar recording links and PowerPoint resources to our registration list. So you'll be getting that and it will be posted on our website. So we hope to see you all soon at a future medical respite activity. Thank you, everybody.